This presentation will cover Chapter 49 regarding care of patients with eye and vision problems. The first problem we'll address is cataracts. Cataracts essentially is an increase in the lens density where the lens becomes opaque. The most common cause of this is aging. It's pretty common as we get older that the lens becomes more dense and it becomes opaque, and so it's difficult for the patient to see, leads to blurred vision that sometimes the patient doesn't even realize how bad it is until it's restricting them. There's a few other causes for cataracts, but like I said, aging is really the most common cause for cataracts. The other thing about cataracts is people tend to get them more in areas where there's a high exposure to heavy sun. So, in your climates such as maybe Florida, your warmer climates where they're out in the sun more often, and even people who have maybe an occupation that exposes them to the sun over time, they're more at risk for cataracts as well. A few other causes, trauma, exposure to toxins could also potentially cause cataracts in a patient. There's a table on page 1060, table 49.2, that talks about all the different causes for cataracts. This picture just gives you a visual on where the cataracts are in the eye as far as anatomy and physiology. So it's the lens portion. The lens is what focuses on an object for us to see. And so that lens becomes dense and it's very cloudy and opaque. So the picture that the patient sees is blurry. So signs and symptoms of cataracts, typically blurred vision, like I said. They also have a decrease in color perception, causes double vision as well for the patient. And basically what happens is when the patient gets to the point where it's affecting their driving, it's affecting them taking care of themselves because their vision is so impaired, it's not safe for them, they will just go ahead and recommend that they have surgery because there is no cure for cataracts other than surgery. Without surgical intervention, it will lead to blindness. So like I said, the provider will typically, when they really start having some trouble with getting around, doing the things that they normally do, they will recommend that they go have surgery. And the surgery is usually a lens implant. They will remove the old lens and extract the old lens by a procedure called a phacoemulsification. It's basically where they put the probe in and they'll kind of break up the old lens and then they'll suction it out and then put a lens implant in. It's a one-day surgery. They're in and out. Basically a pretty easy procedure these days for patients to have performed. Pre-op teaching for a patient is you got to go ahead and make sure that they are going to be able to do eye drops because it's going to be very important for them to be compliant with eye drops. So pre-operatively, you would want to assess them for the ability to understand how to do eye drops and to be able to perform it. If they can't, you're going to have to determine a way, maybe home care, make sure they have a friend, bring a friend or a family member in to teach them how to do these eye drops because they really need to be strictly adhere to the regimen for eye drops post-operatively to prevent infection. Other things preoperatively that you need to do, you need to determine if they're on any blood thinners such as warfarin or Pradaxa, anything like that. They'll probably have to come off of this for a couple of days prior to surgery. Make sure they have the consent signed. Make sure that you're going to assist with making sure they're going to be lightly sedated for the procedure. And they'll go ahead and preoperatively, they'll usually go ahead and put some eye drops in their eyes to dilate their pupils. In the surgery setting itself, intraoperatively, they'll go ahead and do the lens implant. It's pretty quick and easy. They're in and out in a couple of hours if all goes well. Post-operatively is probably the biggest intervention for the nurse because it's a lot of teaching for these patients. Antibiotic eye drops first, and then they will need steroid ointments, and that's to keep the inflammation down. And there's a really strict regimen that they have to follow, typically for about 7 days post-operatively. So you got to make sure that they're going to have the means to be able to do that. They usually have them wear some dark glasses when they're out in the sun, especially if their eyes are dilated for a while. So there's a lot of rules about their eye drops. The information that you will need to give them regarding their eye drops, there's a chart in chapter 48 on page 1044. Chart 48 talks about application of eye drops, and you will need to know that for module 12 on how to best apply eye drops. The other thing is the decreased activity. For about a week post-operatively for cataract surgery, they're going to have to decrease their activity a bit. There's just a small amount of activity decrease that they'll have to do. On page 1059, it's in chapter 49, I believe it's table 49.1, it talks about activity that will increase your intraocular pressure, and that's what they need to focus on. They do not want to increase that pressure at all. So they're going to have to avoid some things, and a lot of that's like bending over, sneezing and coughing, blowing your nose, straining to have a bowel movement, vomiting, things like that is going to increase their intraocular pressure. So they want to avoid all of this activity to the best of their ability. Lifting objects weighing more than 10 pounds is another thing on that list. So they're going to have to avoid this stuff for about 7 days post-operatively, depending on the patient and depending on the surgeon on how many days exactly. But typically it's about a week post-op that they have to avoid that activity to avoid any complications from cataract surgery. Big complications is the risk for eye infection. So like I said, they're going to have to make sure they do their drops. They're going to have to monitor for complications. So you will need to teach them the things that they need to call the physician for. Things that they're going to have to call for is pain in their eye, any increased pain, bleeding, any weird discharge, especially discharge that's green or yellow that looks like, this could be infected. Any edema, your typical signs and symptoms of an infection is what they're going to look for, and they're going to have to give their doctor a call if they start experiencing any of those signs and symptoms of infection. This is just a picture that kind of gives you a visual on the cataract surgery that we just discussed. And again, just all of those things that the patient will have to do post-operatively after cataract surgery. It's very important. If they stick to this regimen and they get the antibiotic eye drops and the steroid eye drops in, like they should, wear their glasses, reduce their activity, then they should do absolutely fine. Most people recover very well from the surgery and are shocked to see how well they can actually see after they've had the cataracts removed. Once they do that, they can't believe how bad their eyesight was. Again, more home care teaching. Again, just kind of reiterating how important post-operative care is for a patient post-cataract surgery. If everything is adhered to as planned, they should do just fine. So moving on to glaucoma. Glaucoma is a disorder of the eye that is related to the pressure in the eye, the intraocular pressures. Pressures is referring to basically the fluid that's in the eyeball that makes up the eyeball, which is the vitreous humor and the aqueous humor. Vitreous humor is in the posterior portion of the eyeball, and it is something that you're born with. It's something that never changes, that amount of fluid. But the aqueous humor is in the anterior portion of the eye, and it is constantly changing. So the aqueous humor is continuously being made and reabsorbed to keep the eyeball fluid and moist. but it's continuously made and reabsorbed at a rate of about 5 milliliters a day. So not a lot, but just 5 milliliters per day. And for the intraocular pressure to remain normal, there has to be a good balance between that production and reabsorption. So what happens a lot in glaucoma is if something causes a disruption in this flow and this continuous production and reabsorption of it, if there's something that blocks that flow, then the pressures could get abnormal. So when the pressures get too high within there, then it compresses on a lot of the other organs within the eyeball, like the optic nerve, compresses on the areas back there, and it decreases, compresses on the blood vessels, so it decreases blood flow to the eyeball, which definitely can cause ischemic areas. And essentially, if it's not treated, if it's not found and treated, it could actually cause blindness because of the damage that the increased pressure puts on the blood flow to the eyeball. So this is not something that a person may be aware of. If they have increased intraocular pressure, it doesn't cause a lot of pain or discomfort. So it's not something that a person would really be aware of until maybe it's too late, until there's been some ischemic damage done. So that is why on most doctor's appointments, as far as if you go to the optometrist or any eye doctor, they're going to check that intraocular pressure, and that's why they do it. They check it to determine. It's sort of like a blood pressure thing. It's kind of like that silent killer. It's not something that is real apparent and makes the patient feel really bad, but could be doing its damage kind of silently. So that's why it's something that is screened by most eye doctors. So you got several kinds of glaucomas. There's primary, secondary, and associated glaucoma. Primary being your most common form of glaucoma, usually is in both eyes. No symptoms in the early stages, usually caused by a decrease in the outflow of the fluid in the aqueous humor through the chamber. There is a more acute primary open-angle glaucoma that actually does cause some pain. It's usually a sudden onset and is an emergency, but that definitely is not very common. You're definitely going to see your primary open-angle glaucoma more commonly than the acute type. Tonometry is what the physician uses to determine intraocular pressure. Tonometry is explained in Chapter 48, so make sure you just review that because it's definitely one of the most common tools that they use to diagnose glaucoma. These are just some pictures that just gives you a visual on where the areas of damage may happen because of the increased intraocular pressure. It's usually back towards the back and compresses on that optic nerve. Just another picture to just sort of give you a visual on the effects that glaucoma can have on the patient's eye. These are, again, just tools that the eye doctor or the physician may use to diagnose glaucoma. Tonometry being the most common one, so make sure you review, especially the tonometry. Optic nerve imaging really is just done basically to determine how much damage has been done to the nerve by the glaucoma, by the presence of it. There's also a care plan on page 1064. It talks all about the care of a patient with glaucoma. It's probably a good idea to read through that. It's kind of like gives you a little case study in the care that would be the most common care and how that patient would be handled. Okay, important thing with glaucoma. Like I said, it requires early detection, and that's why the physicians are doing early screenings. It's something that's usually done every year to check patients' intraocular pressure. Once they are determined to have glaucoma, they will require lifelong treatment. It's not something that goes away. They are going to require using eye drops and medication for the rest of their life, and they're going to need to really follow up with their eye doctor to make sure that the treatment is effective, or they could become blind if they're not following a regimen and following up with their physicians. So eye drops are the mainstay of treatment for glaucoma. Treatment is focused on reducing intraocular pressure. They do not fix what has already been damaged, but they should be effective in treating any further damage that will occur by decreasing the intraocular pressure. But like I said, the damage that's been done, it can't do anything about. But they will, if they use the eye drops as ordered, it will prevent them from having any further damage. You have a great chart on page 1066. The chart is 49.7 regarding the eye drops that are given for a patient with glaucoma. One of the most common ones that you will see is Tim Optic eye drops. If you look, they are a beta adrenergic blocker. One of the most commonly used eye drops for glaucoma. This eye drop works by blocking the beta adrenergic receptors in the eye, and so less of the aqueous humor is produced, thus reducing the intraocular pressure. If you notice the side effects of the beta adrenergic blockers, there are a lot of the same side effects as the beta blockers that we talked about regarding blood pressure and cardiac patients. They should not get the systemic effects of these eye drops, but they could. So they need to sort of be aware. Diabetic patients need to make sure they monitor their blood sugar levels and check their pulse too. If their pulse is getting low and they're on an oral beta blocker, those two together could really lower their pulse. So they need to kind of make sure that they monitor that. So take a look at that table. I believe there's a few others that are pretty common. Xalatan being the other one, which is latanoprost. Those eye drops are on there. Just kind of look at how these work. Again, the goal of all of these is to reduce the intraocular pressure. They may work in various ways, but the goal of all of them is to decrease that intraocular pressure, to decrease any more damage that could be done to the eye. Teaching with these patients, you're going to make sure that you teach them to take those eye drops, and they need to take them as they're ordered. So again, knowing how to teach a patient to administer eye drops is a very important part of Module 12. And you also need to teach a patient with glaucoma about the late manifestations of glaucoma. So make sure they need to report any signs and symptoms of any severe optic nerve damage, such as seeing halos around lights. Losing peripheral vision is a real important part that they need to report very soon. That's letting them know that their damage from glaucoma is getting worse. If they begin to have decreased vision that does not improve with glasses, the loss of peripheral vision, or halos around lights. And I think that's in that concept map there. It talks about teaching for a patient with glaucoma to make sure they report any of those signs and symptoms that their vision is getting worse instead of better. A couple other big things to note about patient with glaucoma and eye drops is a lot of times they'll give them more than one of these eye drops to use to kind of sort of like the blood pressure medicine, how they're on more than one. We're trying to hit them in a couple different areas to decrease that pressure. They need to make sure that they wait about 10 to 15 minutes between instilling eye drops, so that each eye drop has an opportunity to do its job before you go in and wash it out with another eye drop. You have to make sure you wait between each one. Also, make sure that you teach them about good hand hygiene if they're going to be sticking their hand in their eyeball. Make sure they're washing their hands before and after doing that. Okay, moving on to macular degeneration. It is exactly what it says it is. It's a deterioration of the macula of the eye. If you review your anatomy and physiology, the macula of the eye is the area of central vision, central being the key word there. Couple different reasons, couple different types of macular degeneration. Age-related is the most common type. Exudative is the other. Age-related macular degeneration has two types, of course. There's dry age-related macular degeneration and wet age-related macular degeneration. The big difference between the dry and wet is if you were given a choice, you would probably not pick dry, mainly because dry age-related macular degeneration is more common and it progresses at a very faster rate. Essentially, what happens with macular degeneration is they begin to lose their central vision, and it most likely will lead to blindness, which leads to difficulty with independent living. A lot of times these people will lose their independence because of the blindness that it causes. So safety is a big thing with these patients, and just kind of trying to maintain their independence for as long as possible. There is currently no cure for a patient with dry age-related macular degeneration. Basically, they just try to focus on slowing the progression if they can and keeping the patient safe and helping them to do what they can as they lose their vision. There is some thought processes out there that thinking that if they increase dietary intake of antioxidants, vitamin B12, and some lutein, that appears to slow the progression of macular degeneration. So typically that's pretty much what they're going to be putting the patient on as of to date. I know there's a lot of clinical trials out there. They are really aggressively, especially I know we have Cincinnati Eye Institute here in our city that does a lot of clinical trials on treatment for macular degeneration, because it's kind of common, so they're trying to figure out a way to help these patients. So if you look back at your anatomy and physiology, if you look back at what your retina is, it's the innermost layer of your eye. It's the area where the sensory receptors are that transmit the impulses to the optic nerve. If you look back at what the optic nerve is, that takes your visions that you see. That is how you see and interpret what you see. So the retina is pretty important. It has those rods and cones. And if you remember, your rods and cones is what help you determine light and color. So those are also on your retina. So a retinal detachment is a pretty important, tragic thing that can happen. Not tragic, but it could really impair your vision if the retina does detach. It's where the separation of the retina from the epithelium. So a retinal detachment is typically something that happens pretty suddenly. They don't have any pain because there's no pain fibers in this area, so there's not really any endings that would give them pain. However, their vision is going to change. They're going to see sudden bright flashes of light, floating dark spots. So it's going to be kind of an acute change in their vision that's going to trigger the patient that there's something happening. It's not going to be a painful circumstance for them. 3 different classifications of retinal detachment. The regomatogenous detachments are usually something that happens following a hole or a tear in the retina caused by some kind of a force. Sometimes this can be like a trauma that can cause it. The traction detachment, again, is when it's just pulled away. Like the fibrous bands. You don't really have to know the exact causes, but just know it can be from like a traumatic injury, or sometimes just aging causes the separation to occur. A common complaint for these patients is they will describe it as a curtain being pulled over part of their visual field. So it's like there's certain things, like a side, like the right side, they might not be able to see as well as the left side. So the sudden change in their vision is always a little bit traumatic for a patient. It's a little scary when that occurs. but typically can be fixed fairly easily. It is a surgical procedure that most patients will have to go have done in order to repair their retinal detachment. And the type of intervention is going to be related to the type of retinal detachment that it is. Some can be fixed by just some cryotherapy, which can freeze it, or some diathermy, which is a high frequency current that can actually to repair it. But the most common thing is the scleral buckling, and that is pretty, fairly easily done. They do have to put them under general anesthesia for this, to be able to get to the retina for that surgery. But the big thing afterwards is they will need to use an eye patch after surgery, and just monitor. And again, they'll probably have antibiotic eye drops that they'll need to be instructed on how to utilize in order to prevent any complications post-operatively. They'll need to prevent infection, wash their hands, make sure they put their put their eye drops in, and then there's going to be some activity restrictions as well. And they will need to notify the surgeon immediately if they have any concern or signs and symptoms of infection, because they'll want to make sure they get that treated immediately so that they don't lose any vision in their eye. Refractive errors are just referring to a lot of the vision disorders that is very common in most people today. And basically it's just talking about how the light, the refraction of the light shining on the retina. So myopia is simply nearsightedness, and that's where the eye over refracts the light on the retina. So the images fall in front of, not on the retina. So that causes nearsightedness. Hyperopia is farsightedness. So the refraction is too weak, and it's basically just causing an abnormality in where the images are focused on the retina, so it goes behind the retina in hyperopia. Presbyopia is when you're just having age-related changes. The lens loses its elasticity and it's less able to change shape to focus. So that's presbyopia is essentially referring to the visual changes that occur as the patient grows older. Astigmatism is another refractive error, and that's basically the curve of the cornea is the culprit there. It's uneven, so the cornea is that outer covering of the eye, and so when that is the curve of it is uneven, the light is refracted differently on the retina again because of that, and so there is some visual changes for that patient. Lucky for us, they've come up with multiple ways to fix these refractive areas, whether it be glasses, and now we have a lot of surgical intervention that is pretty common these days, the LASIK surgery. So a patient has multiple choices for treating refractive errors. They can just simply wear eyeglasses. That's pretty easily, if they go to the eye doctor, they can get them a prescription, and that can be pretty quick. If they choose not to wear eyeglasses, they can wear contact lenses, which will require a little bit of teaching. It's a little bit of skill to be able to put the contact lens in your eye. And there's a lot of teaching as far as care. Again, it's washing your hands, doing this in a clean manner, wearing contact lenses. So that would be some teaching for your patient as far as application and removal of the contact lenses, if that's what they choose to do. If they choose LASIK surgery, it's a pretty quick in and out. Usually their vision is corrected within the hour after surgery. So it used to be they couldn't do a whole lot with astigmatism, but now I'm hearing that they are able to fix astigmatism with LASIK surgery. So that's that's again a great choice for patients, because their vision can be corrected without the use of the corrective lenses. So if they have the LASIK surgery, they're good to go. But as far as the surgery, it's sort of like all of your other eye surgeries. Post-operatively, they're going to have restrictions. They're going to be using eye drops to prevent infection. There are a few complications from LASIK surgery, although they're getting better and better at this every day. There's some cloudiness that can appear after eye surgery, corneal clouding, chronic dry eyes. And then they're saying that for about 10 years this is effective, and then after about 10 years post LASIK surgery they might have some vision changes and need of revision in their LASIK surgery. But all in all, I think it's been pretty successful in treating people for refractive errors. So this slide really is a summary slide for all patients with visual impairments. As far as interventions for a nurse, basically communication of all the things that they can have to help them maintain their independence and their safety. Anybody that has any kind of a vision disorder is going to be at risk for injury, falls, burns, things like that if they're not able to see clearly. And they're going to need help with ambulation, especially if they have macular degeneration, things like that are causing very serious vision changes. And so the role of the nurse is to basically make sure that they can maintain their safety, their independence, and their dignity, and their self-worth if they're losing their vision. That can be pretty hard on somebody, especially maybe if they're losing their privileges to drive, to take care of themselves. That's kind of hard on the patient. So the nurse is really, the role is to try to maintain all of that, the safety, the independence, and the integrity of the patient. And that concludes Chapter 49 regarding patients with eye and vision problems. The following slides, case study and some questions. I encourage you to look through those to kind of help your understanding.